I would like to acknowledge Samresh for helping me out in this presentation. I think with the evolution of all of us as improved cataract surgeons, so as to say, pre-operative evaluation before a cataract surgery is gaining more and more importance. It's no longer just a few measurements done by the optometrist or the technician and you just selecting one IOL power based on what the IOL calculation sheet shows. And so I think now all of us need to start formulating a strategy for all our pre-operative workup patients. At our clinic, this is something that I would like to proudly share, that we keep a separate pre-operative clinic for all the patients undergoing cataract surgery. That is, they come at a dedicated time slot where we are able to spend more and more time with them and understand their needs and their eye much better. That would mean having a dedicated team of not only the doctor but also the optometrist and other allied staff. Also, always make sure that you take measurements of both eyes. Take the patient as a whole and not just the only eye that you are going to operate. So evaluate both eyes comprehensively. You may be surprised from time to time in the eyes that you are not going to operate. This is something that sounds schoolboyish, but I find it very, very useful. Very often in busy clinics, while talking to the patients, the talk gets diverted and we tend to forget some things that would normally be a part of our routine pre-operative workup. So always have a fixed written pro forma. This is something I always find very useful, where I make sure everything has been entered correctly before I call the patient for counseling. Now before moving on to all of these, these are just representative photographs, but probably 20, 30 of more of these fancy gadgets to measure different parts of the eyes. It's foremost importance that to create a happy patient, the first evaluation that needs to be perfect is that of the ocular surface. So always make sure that the ocular surface is in good health, and patients having a poor ocular surface need to be treated first before taking some of the corneal measurements and also before performing cataract surgery. Simple tests like these. This is just an infrared photograph of the autorefractometer that all of us have, showing areas of meibomian gland dropouts. Now coming to some of the fancy newer investigations that are on the anvil. First, the abrometry. We find the abrometry quite useful now, not just for the LASIK practice, but also extremely important for the cataract practice. The abrometry gives an objective assessment of the patient's vision and his total eye aberrations, which helps us not only in finding out from where these aberrations are coming from, but help us in counseling the patient as well. To simplify this complicated printout, the abrometry there's a ray tracing abrometry where the total eye aberrations are measured and the corneal aberrations are done using a Placido-based topography. Subtracting the total eye aberrations from the corneal aberrations, we get what we know as the internal aberrations, which in most cases are likely to be arising from the lens. The corneal aberrations being done by the Placido-based topography system. This also gives us the SIM-K values equivalent to our Placido-based topography, and importantly it also gives us the pupil size, which gives us a rough idea how much the mesopic pupil of the patient dilates. This may also help us in selecting the type of IOL. The point spread function helps us to assess the actual quality of vision that the patient is having currently with his lens. Let's go through some interesting case scenarios. Now this is a case with a fairly advanced nuclear cataract, but notice the corneal endothelium. There are plenty of guttates here. So he's a case of advanced Fuchs dystrophy with no apparent clinical decompensation of the cornea. We decided to take all the corneal protection precautions, and we did an uneventful cataract surgery with an aspheric IOL in the bag, and we were patting ourselves that the cornea has remained very clear, no decompensation of the cornea. But the patient wasn't very happy. He just came coming back to our clinic saying, you know, whatever you may say, I'm able to read the last line, but the quality of vision is not great. The anterior segment looked very clear, but then we put him on the abrometry and look at what we found. There are so many aberrations coming from inside the eye. So that helped us to understand what this patient must be going through. When the rays of light pass through the corneal guttates, they lead to diffraction of light, and that leads to all of the internal aberrations that he was having. So this helped us to understand that in patients having a poor corneal endothelium, they are the cause for the predominant internal higher order aberrations. So possibly these are the cases where, although we may feel confident with our cataract surgery, we may want to avoid the so-called premium lenses or multifocal lenses or even the aspheric IOLs. This is a second patient, having a 52-year-old male planning for cataract surgery. And in my enthusiasm after doing all the corneal workup, I suggested a toric IOL. But he shot back at me that, are you mad? I've never worn cylindrical glasses ever in my life, and you're telling me I need a cylindrical lens? So here the aberrometry helped us as a tool for counseling. We could show him that his entire corneal astigmatism is currently being neutralized by the internal astigmatism produced by the lens. Needless to say, after cataract surgery, this internal compensation is going to go away, unmasking the corneal astigmatism. So this helped us to counsel the patient correctly, gave us an objective documentation that his hidden astigmatism would be unmasked. And rightly he went ahead with a toric IOL, and this is the post-operative of the same patient where the entire corneal astigmatism is almost completely being covered by the internal astigmatism corrected by the toric IOL. So the aberrometry here helped us in understanding the internal compensations of the natural lens and helped us as a pre-operative counseling tool. Now coming to the angle alpha for the cataract surgeon, the angle alpha kappa switches off me at any point of time. But this Samresh helped us to help all of us to understand the importance of these different angles in planning IOLs inside the eye. So the eye trace aberrometry here gives us the center of the limbus, the center of the pupil, as well as the center of the visual axis. Now routinely the IOL would center to the center of the capsular bag, which is generally equivalent to the center of the limbus. The angle alpha is the angle between the center of the limbus and the visual axis. So when the patient has a large angle alpha, like here, where the center of the limbus and the visual axis is quite far apart, when the IOL centers to the center of the limbus or to the center of the capsular bag, what you'll notice here is that the visual axis passes through the area of the rings of the multifocal IOL. And therefore this patient is likely to have lot of post-operative issues of light, sensitivity, glare, dysphotopsia, etc. So this helped us to understand or sort of decode many of our apparently 6/6, N6 multifocal patients who were never happy with their quality of vision. And from then on, we always consider that patients having an angle alpha of more than 0.4 millimeters are a big no-no for selecting multifocal IOL patients. Any examination is incomplete without the size of the pupil that we would want to know, because pupils which dilate more in mesopic times tend to have increased internal aberrations, which may help us in deciding the type of diffractive IOL which we may or may not want to suggest to the patient. Retinal examination, like all of us have been taught in our teaching times, is extremely important, not just of the central retina, but even the peripheral retina, which may be needed to be treated before cataract surgery. But very often we do find that in dense cataracts we apparently see a dull foveal reflex, and post-operatively patients are never happy with the quality of vision. And that is where we find the role of OCT very, very important before cataract surgery. So now as a rule we do a pre-operative retinal posterior segment OCT for all our patients undergoing cataract surgery. We did a prospective study where in a clinical diagnosis of a normal fundus done by our retinal surgeon, we could find that in 7% of cases there were ERMs detected on OCT, 4.5% there were RP irregularities, and in up to 3% there were vitreomacular tractions and foveal problems. So you can imagine if any of these patients were being counseled for premium IOLs, they would never be happy with their post-operative vision. This is a clinical example of a normal looking fundus where even the retinal surgeon had said normal fundus, no macular pathology. But the OCT showed a fine epiretinal membrane. A similar patient off the macula showed a persistent pigment epithelial defect. And this is a case of a normal looking dull foveal reflex having a lamellar macular hole. So I think retinal preoperative OCT is now almost needs to become a part and parcel of preoperative investigations and is no longer just needed for known retinal diseases. Coming to newer corneal investigations, are they really needed? All these fancy topographies or pentacams and Galilea, are they needed? More and more we are finding that there are many patients where on the measurements of manual keratometry you do get astigmatism, but when you do a topography they may not have a regular astigmatism pattern. Therefore, topography or corneal imaging devices help us to first of all detect the regularity of the astigmatism, which is very important because it's only in regular astigmatism that can be corrected with toric IOLs. More and more the role of the posterior corneal curvature is also being highlighted, where most of our keratometries use only a fixed ratio between the anterior and the posterior curvature. Newer investigations like the pentacam or the Galilei measure both the anterior and the posterior corneal surface, and as Dr. Douglas Koch has highlighted in his landmark paper, patients with against the rule astigmatism may need to be overcorrected versus with the rule which may need to be undercorrected. Also, the pentacam or the images which give the imaging of the posterior corneal curvature help us to rule out certain gray zones. For example, this patient has a very high posterior corneal curvature suggestive of a form fruste keratoconus. So these are the patients which we can avoid putting multifocals or other kind of premium IOLs. So not only is the corneal investigation important to do the magnitude of astigmatism, but also for the regularity and to rule out certain corneal diseases which will be missed on normal corneal investigations. So I think newer investigations, there is no end to it. You may have a $1 zillion budget and you may still be short of 5 instruments that may be available in the market. But I think definitely they do have a role. They have a role in raising the bar of our cataract surgery, which all of us have raised as far as our surgery goes. And it helps in improving the predictability and precision of cataract and refractive outcome, which I think is going to get more and more important in the times to come. So definitely an additional burden as far as the cost goes, but I think it's going to be worth the while in the long run. Thank you.